hospital is reaching at 9.
How do I turn the video on?
Sorry, किसको फोन कर दिया मैंने? हेलो, अरे दीपाली, मैं तुम्हें बोलना भूल गई, वो डॉक्टर अनु जैन के 2 पेशेंट्स थे ना, तो मैंने बता दिया था टू सेंड द
needs attention. And suffice to say that it is logical that it would have an effect on, it would have an economic effect as well on our national GDP, and it's a burden for the system, and so requires public health attention also. Okay, so multiple complications are associated with obesity, and I know that I could name quite a few, but if you look at this slide, over 229 possible complications affecting every organ system. We know the obvious ones: type 2 diabetes, hypertension, CAD, CHF, but even things like colorectal cancer, prostate cancer, and now even associations with dementia. So it's, yeah. And the risks arise from a phenomena called lipotoxicity, which is basically the accumulation of fat in visceral tissue, and it then starts to affect other areas such as the pancreatic fat, intramyocellular, and perivascular fat, which leads to problems. We'll get into that in just a minute. Okay, so let me follow through with. Okay, what leads to obesity? So traditionally, we thought obesity or overweightness was basically the balance between energy in and energy out. Well, it's not as simple as that, and it's actually a complex interplay of signals between the central nervous system, peripheral signals, energy balance from adipose tissue, GI tract, environmental food cues, and a very powerful biologic drive to defend the highest weight achieved. And when we the obesity epidemic, one of the answers is to eat less and move more. Sure, they're not wrong, but I would say that that's an oversimplified answer. And let's see why. So, remember from, I know that there are young ones here, but many in my age, we remember from our med school that the brain basically controls the signals for eating. There is a complex interplay between those hormones for satiety and those for hunger. And satiety, to name a few, because I know Dr. Madan will refer to then how the drug acts, would be GLP-1, PPY, oxyntomodulin, pancreatic polypeptide, leptin, insulin. These are all hormones that reduce appetite or anorexogenic. On the other hand, ghrelin promotes hunger, and it's called an orexogenic hormone. So this is sort of the first level of what controls our appetite and hunger. And these signals come from various peripheral tissues as well: adipose tissue, gut, pancreas. I'm going to show you a further diagram. So again, nobody's doing a test after this to ask you what arcuate level first order neurons are, or the second level ones are, or POMC and CART, what are they doing? But basically, to understand that there's this symphony of neurochemicals and hormones that are levels of the hypothalamus, first order, second order neurons. That's one. Also, there are direct vagal afferents that get to the blood-brain barrier, certain areas of the brain where the barriers are a little bit leaky, called the nucleus tractus solidaris and an area postrema. So this complex interplay is basically what controls our appetite, hunger, gastric emptying, metabolic rate, and the drugs that we talk about when we talk about weight loss are acting on many of these hormones, and of course many others are in the pipeline, which also will be targeting some of these neurochemicals. All right. The second level of eating is basically the brain's reward system. So this is called hedonic eating. We're all aware of this. Vijay was having cookies that he wasn't hungry for. So this is basically wanting, which is influenced by the dopaminergic neurons, and liking, which is controlled by the opioid and cannabinoid systems. Small little difference here. So the dopaminergic neurons are really powerful. They control wanting, and the delicate ones are the liking ones. And one example could be in drug addicts. So they want the drug, So, as I said, there have been studies done on these areas. They may not necessarily like the drug. Showing you that there's a bit of difference here, but this is the second level which controls eating behaviors, hunger, society, and satiety. The third level is our executive functioning, which is controlled by the prefrontal cortex, and that's the site for our behavior intervention. So, for example, this is what comes into play when you are hungry and you open the fridge and you want to reach out for that bar of chocolate or a scoop of ice cream. You see an apple sitting there, and you actually pick up the apple. So that's your executive prefrontal cortex coming into play. You have one of my colleagues sitting there whose words are ringing in your ears. There's some nutritionists also here who are ringing in your ears that you should be making the better choice, and that's your executive functioning. So good to know some of this as we tailor our advice to patients, because that's eventually the end goal. Why doesn't everybody in a family develop obesity? Because the causes for obesity are complex and heterogeneous. I've already mentioned the biologic pathways. Then there are socio-economic environmental factors: age, sex, race, geographical areas, food environments, psychological reasons, mental disorders, chronic stress, genetics. Obesity is a heritable disease influenced by interplay of genetics and epigenetics, and there are more than 200 obesity loci that they found. Medication can cause weight gain, and it's important to be aware of these when you are planning for weight loss advice. Antipsychotics, antidepressants, to name the common ones, but even antihistaminics, something as common as that. Other factors are, coming to this. Other factors are gut microbiota and EDCs. So the gut is now being referred to as a second brain with over 1 trillion microorganisms, and there are certain bacteria, the ones that come up frequently, Bacteroides and Firmicutes. The ratio between these two has been found to play a role in obesity. So if the B to F is higher, it's better for weight, and if the Firmicutes go up, then that leads to more obesity. So fatty diets also shift this microbiota. It's important to understand. Because of fermentation, all of that, the composition of the gut microbiota changes. And to me, this is probably the basis for some of the areas that I'm learning about but not practicing. Again, nutritional and health coaches, functional medicine, they're all working with these areas, and we're getting more and more information. As you all know, that it's one of the hottest topics even on social media, so it's around us. And a lot of people are playing coach and suggesting supplements that our patients will often come up with. So again, these are some of the areas and the science that we need to keep in mind. One other factor that I was going to mention was EDCs, or endocrine disrupting chemicals. So these also change the composition or change our hormones, and these are in our everyday life in things like shampoos, so parabens or non-stick cookware, halons, plastics that we store food in, and that's why we try and stay away from all of that. Okay, so why is it so difficult to maintain weight loss in the long term once obesity is established? Most of us know that if we've ever tried weight loss, pretty much the graphs look like this. You lose weight in the initial few months, and then it plateaus out. And so basically the body tries to maintain a set point of weight. If we talk about the physiology of weight loss, the brain recognizes the fat loss and compensates with increased calorie intake, as well as dropped energy expenditures. And so basically what you have control over, if you're watching your diet and lifestyle, is what you're doing, and sometimes not on weight itself. Because as we learned earlier, that the reasons for weight gain and the body to come back to its set point are a complex interplay of neurohormonal changes, and those they've seen in multiple studies, those come into play once the body drops weight. So to also give you an example, body has a set point for weight, and it's a very complex, fine-tuned system that we're only now in the past few years learning about. For example, when a girl reaches menarche, generally she tends to put on weight, or when she's pregnant, she tends to put on weight. These systems are controlled by neurochemical hormonal changes in the body and also come into play when somebody is trying to lose weight. The body will fight back and try and come back to a set point. So this aspect is also important to remember as we get into therapies and treatments for weight loss. This graph basically shows that if people are doing the lifestyle changes, after a while, they will regain back the weight. The body will start to bounce back through multiple mechanisms. However, if they are on medication, on treatment, then those graphs continue to stay low and weight continues to stay down. I'm going to just carry on and finish, Kaushal, before I invite you in. So we talked about the science and the complex interplay of hormones in obesity. Just going to go through the basics of obesity assessment. So I think I've asked this when we all came in. People may be coming to us for various different reasons, but we can spot the obesity or the overweightness. And now we've seen that over 229 conditions at least are associated with obesity, and more research is coming up. So are we having those conversations? And how should we have them? So tip of the iceberg, basically, many people think about 30% that they don't have a problem with overweightness. And we especially have this phenomena, I think, in India, khate pite ghar ka hai, and ya ghar ki hai. And only about 41% actually receive the diagnosis. So I'm not about to teach you how to manage your clinics, but I think with obesity, just like any sensitive topic that we're bringing up with our patients, the first thing is, especially if they've not come to you with obesity, but you can see that it's a problem. My ENT colleagues are here. They are coming to you with sleep apnea, with snoring. They may not be bringing up obesity, but you need to. And so the first thing is to ask, would you like to talk about your weight? They may say flat out no. And I will have to ask questions. And so then you basically wait for the time that they're ready to have that discussion. Assessment. So assess their stories. Obviously, when you're talking to them, goals that matter to them, just like any other clinical conversation you're going to have with them, and classify their obesity and disease severity. We'll just go through these. How do you classify them, and how do you score their severity? So basically, this slide summarizes how do you assess obesity. You confirm the diagnosis. Most common is the BMI, height, weight, BMI. Waist circumference, it's advised that for the Indian population, definitely do check the waist circumference because we have this phenomenon called the thin fat, and there are waist to height ratios that you can compare against, and otherwise it may be pretty misleading. And that abdominal obesity also correlates to morbidity and mortality as much as just outright obesity. Take a comprehensive history as to the root causes of weight gain, complications, barriers to treatment, of course. Stage the obesity if you can, if that's the consultation for you. I'll come to that. There is an Edmonton obesity staging system, which actually classifies the severity of the problem and helps you look at various consequences that the obesity may be causing, and you get a risk score. So I'll come to that in a minute. And then implement obesity treatment guidelines in your clinical practice. I just mentioned that in India, we're supposed to look at both waist circumference, this is the ESI, our Endocrine Society of India, as well as BMI. And actually, our BMI cutoffs for Indians are lower than the global ones. Obesity is classified anything over 25, but globally it's 27 to 30. Over 30 is obesity, 27 to 30 is overweightness. So we are a little more strict with our Indian population. We talked about this. What are the things you're doing in your obesity assessment interview? Coming to the Edmonton obesity scale. So basically, once you stage the patients, actually the higher scores, 2 to 4, they've done these studies, the diverging graphs on the left side basically show you that they have a higher health risk and prone to mortality. So it's a good validated tool, which brings me to our weight management program on DocGenie. This is what patients see when they come to our landing page. We have a virtual obesity clinic, and it's run by doctors, nutritionists, physical therapists, physiatrists, psychologists. So not off the cuff, because the drug is available, as you know, quite freely. We have a landing page where the patient enters their weight, and basically they get a pop-up like this. Your weight is such and such, overweight category. You get a call to action, get a plan, enroll and see somebody, get a consultation. So again, the assessment that we talked about, put into clinical practice. And then of course you enroll in a plan. And we've done only BMI here and not waist circumferences because we feel that there might be difficulties in patients measuring that accurately. Once the patient is in the clinic, we also support our clinicians with the EOSS, which is available during the time of consult. They can actually open this form up, fill it while you're talking to the patient. So just check off, and actually give them a risk score, which again, I think helps both the patient to see how serious the problem is and to tailor your interventions. So, yeah, and that's what the EOSS questionnaire looks like. And that's about it from me. So I will hand over to Kaushal, Dr. Kaushal Madan, and we will take questions afterwards. Dr. Kaushal took a call, so I can actually take questions, and welcome to those of us who are here. Okay, good. I'll take some questions in the meantime, and then Dr. Kaushal can. Any questions? Hanji, Dr. Singh.
Ma'am, your slides are much different than what we have seen in the previous presentations.
Okay.
And that is very nice
Oh.
because it is different from that way. And my question is that in this drug, everybody says that the patient lose 60 to 70% of the fat and 20 to 25% of protein. And those tries to take rigorous exercise and protein diet. Non-vegetarian can take a non-vegetarian diet and they can take protein. Vegetarian people cannot take the proper diet of 1 gram protein per kg of the weight. And those patients who are suffering from any of the bones, joint pain or something, osteoporosis, they cannot do the rigorous exercises. And the second thing is we cannot help them because they cannot do exercise. Second is there is a drug called bimagrumab. It's a new drug. And this drug is switch off the formation of fat in the body and switch on activate the muscle formation and preserving the muscle mass. I want to say is if this drug is combined with these drugs, then the mass, protein mass will be preserved and the more fat will be lost and the more weight loss will be there at 15 to 20%. What is your idea about this drug?
Thank you for your questions. First of all, your comment is right about the challenges with being vegetarian, getting the protein intake, and of course, absolutely being on the drugs to make sure that there's strength exercise happening. And so you have to curate and you have to choose your patients correctly. You should. About the drug bimagrumab, I will admit that I am not aware of it. Let me get back to you after I am able to brush up on that. So I'm not aware of the new drug, and let me get back to you on that. And with that, I'll have Dr. Kaushal. Dr. Kaushal, have you seen it?
No, after he just mentioned it, I was looking it up. So it is a muscle sparing drug, which monoclonal antibody, which the people are looking to combine with GLP-1 RAs to prevent the muscle loss or sarcopenia, like you rightly said, but still not FDA approved, still in the development stage.
But in future, treatment of obesity is good.
Definitely, not necessarily obesity, but to preserve the muscle mass.
Yes, so that is more important.
Prevent muscle loss.
Because old men also have got a sarcopenia already, but their sarcopenia cannot be reversed. But we can stop more sarcopenia.
I agree. Absolutely.
Dr. Kaushal, with a raise of hands, who doesn't know Dr. Kaushal Madan? You are going to get a biscuit from here.
They know me because they're from the same college.
A lot of us, right. So, just again, Dr. Kaushal Madan is an eminent hepatologist in the city and the director and head of clinical hepatology at Max Arcade and our go-to hepatologist, gastroenterologist. So, welcome and let's get started.
This is very strange.
Okay, so we can have some more question and answer session with Dr. Rachna till I upload my slides.
Okay, all right, great.
Sorry
we
about
handle
that.
them together. So, just by show of hands, how many of you are actually talking about obesity in your clinics? And also the reason I think to do this session was because it's not just clinics, it's society, it's friends. I'm sure you're being asked about these drugs everywhere. You're on podcasts. Huh?
Socially also. Socially.
Quite a few of our OSC patients have obesity, have high BMIs. But I mean, it's difficult to give them answers how to manage their weight. Because, you know, being ENT practitioners, it's not easy to put them on drugs and diets and all. So, you know, we need a specialty clinic, especially which is addressing obesity problems. You know, I know. So, it's a... Yeah. So it's good to be aware of such a program where you can, you know, refer your patients to, and they are looking at the patient in a more holistic manner where, you know, the nutrition, the diet, and the, drugs are the.
And we have a few of our nutritionists also who joined us here. And Doc, I know you're a pediatrician. How is your clinic experience? I mean, we can all make this quite interactive. How has your experience been?
I'm, I think, relatively very early in my career as compared to other people.
Yes, you are. We can be very light here. I thought somebody's brought their young son along.
Right now, in my clinics personally, obesity is not that talked about, to be honest.
Okay.
Because most of them, even if we diagnose them as being obese, parents generally don't like to talk about that in front of their children, especially adolescents. From what I've encountered. And even if we do diagnose obesity, we first of all start with the general exercise and nutrition management. But drugs, as per pediatrician, I have not personally encountered anyone who has started them on drugs.
Right, fair enough, and that's the right way to go. And you, Doc, I know you're a gynecologist. In your practice, any sorts of areas or reasons why you'd be tackling obesity?
Of course, we do encounter such patients with very high BMI, and how we're going to manage them during their obstetric phase, during their pregnancy antenatal phase. So, of course, that's a challenge that leads to more and more of complications like diabetes, hypertension in such patients. So, we have started prescribing Mounjaros, Ozempic as of now in such patients in postnatal phase. So yeah, it's a little new for us. So they are in the process of.
Thank you. Not allowed in pregnancy.
Not in pregnancy, but in the postnatal phase, we advise them to go for it.
And even if they're planning pregnancy, just to clarify that they should be clear of it at least 2 to 3 months in advance of it. Before.
Yeah, Dr. Kaushal is there.
Yeah, I don't think it's. Then it's not. It would have been good to have some of our derma colleagues because because it's available now without prescription, etc. How many of you are seeing used before events and getting married and get a certain jawline and all of that? Are we seeing that sort of use? Dr. Jain is. Okay.
We are. Yes, he's talking.
Dr. Jain does some cosmetic work also. Anything from our nutritionist colleagues? Are you giving, since it's such an important part to to manage their nutrition when they're on these drugs? Are you getting more patients who are on these drugs and managing their nutrition differently?
Yes, I do. In fact, I get a patient who was already.
Ms. Kamna Singhal, one of our nutritionists, and
My name is Kamna. I'm based out of Delhi, and it's been almost 18 years I'm working as a nutrition wellness coach. Predominantly, my key skill set is into gut nutrition, and it's been more than 5 years I'm working as a functional medicine coach. So the question which Dr. Rachna has just recently shared, it is actually there. Lot of patients are coming to me who are already on Ozempic or Manjaro, but they get a stuck-up point where they are losing their muscle mass and they are not able to manage the consistent weight reduction pattern. And in addition to that, the whole spectrum of health trend, it's talking about obesity, and as we all know, the current budget also focusing towards anti-obesity programs with the kids as well. So we have a greater scope in this, but really the real challenge comes in where the patient is not working actually on the root causes, the metabolic issues which is already there, the hormonal dysfunctions, and the lifestyle poor epigenetics. So if we are including these drugs, we really need to work on their epigenetics. That's the big role. Their sleep quality, their movement, how much workout they're doing, how much protein they are having daily intake. So there are not many areas where we can integrate nutrition strategies with the conventional practices, where we get a middle pathway wherein the doctors and the patients are getting results, but their epigenetic is also improving. And the current health trend is, just to elaborate more, the current health trend is more about illness, wellness, sports, and fitness. And everybody is shifting towards nutrition, wellness. So yes, India is a diabetic capital, so we need to work on integrating the nutrition strategies with this.
Thank you. So I guess Dr. Kaushal is ready to start. Thank you.
So, good evening, and thanks to Rachna, Vijay, and DocGenie. These are all people who are part of DocGenie also, to invite me to this meeting, and of course, Novo Nordisk. So, I'll talk about something slightly different. You must be hearing a lot about semaglutide and weight loss. So, a different angle to it in terms of MASLD. So, how many of you see fatty liver in your routine clinical practice? I'm sure all of you. Fatty liver?
सबके होता है सर, grade 1
Exactly. So, सबके होता है. That means almost everyone is seeing fatty liver daily in their practice. So it's so common that people think that it's part of life, but a lot of patients of fatty liver do progress to advanced stages of liver disease, liver failure, liver cancer. So that's why it's an important illness, especially because it's so prevalent in the community. So these were my disclosure. Just to show you an example of a case, a 55-year-old lady, diabetic for 10 years, obese, BMI 32. I'm sure you would be seeing this kind of phenotype day in, day out. Her ALT was 95, albumin 4, platelet 2.5 lakhs, hemoglobin A1C 8.5, on glimepiride and metformin, ultrasound showing grade 3 fatty liver, borderline splenomegaly. So if a patient like this comes to you with a grade 3 fatty liver report, what do you say? What do you tell them?
Lose weight.
Is that all?
पहले तो पायोग्लाइकोजोन और विटामिन ई दिया करते थे.
Right.
अब
So we'll have a discussion on that also.
This drug is very
So there was a time when a lot of physicians would say, oh, this is so, like sir said, oh, this is so common, forget about it, you'll get, just try and lose your weight and you'll be okay. But unfortunately, this was the fibroscan value, LSM liver stiffness measurement of 18, which suggested that patient already had cirrhosis. And we'll talk more about this. So this is what the prevalence of fatty liver in India is. If you look at this is a study from AIMS. In adults, 38%. So 40% of adult population. And in children, 35.4%. Somebody just mentioned, children, obesity in children. And this is what is the driver of adult fatty liver disease. Because they become obese in childhood, बच्चा खाते पीते घर का लगना चाहिए, and that is the thing which is driving this kind of obesity. And of course, the junk food and lack of activity, lack of outdoor games, more of indoor games, leading to obesity in children and a fatty liver prevalence of almost 35% in the general population. So, like I've told you, there are two most important drivers of fatty liver. One is obesity and second is diabetes. Both are part of the metabolic syndrome, and lo and behold, earlier this was known as NAFLD, and now the international community has changed its name to metabolic dysfunction associated steatotic liver disease, signifying that it is an inherent part of the metabolic syndrome. So you cannot separate it or tease it out from the metabolic syndrome. If a patient has metabolic syndrome, there's a high chance he will also have fatty liver. And based on this, the new definition says that if the ultrasound shows fatty liver and you have one of these factors, either a sugar of just more than 100, a BMI which is high, waist circumference which is high, HDL which is low, triglyceride which is high, or a hypertension. Any one of these plus fatty liver, it is called MASLD. But the most important thing to remember is, again signifying the fact that it is part of the metabolic syndrome, that people do not die of liver disease even if they have MASLD. The most common cause of death in MASLD is also cardiovascular. Second most common cause is extrahepatic malignancies, and third is liver-related deaths. So which are those patients who will die? So the patient I just showed you is the one who is at high risk MASLD. So based on this new definition, these are the subtypes, and you just need to remember these two. The simple fatty liver, which just has fat and no inflammation or fibrosis, and second is at-risk MASLD, or those who are likely to go on to develop end-stage liver disease, liver failure, and liver cancer. So how do you recognize them? The most important driver, it has been seen, is the presence of fibrosis. So more the fibrosis, stage 1, stage 2, stage 3, stage 4, higher is the risk of developing liver-related events, and higher is the risk of all-cause mortality. Like I told you, not only liver-related mortalities, all-cause mortality. But how do you, in your routine clinical practice, test for liver fibrosis? Do you do a liver biopsy? Then how do you do it? Exactly. So now we have a tool. I think all of you must have heard about it. Some of you would have used it also. It's a simple machine which is kept in the OPD. So just sitting in the OPD, you can give patient two values, two readings, two information. One tells you how much fat is there, it gives you two values. This ranges from 100 to 400. Anything above 240 or 245 is considered fatty liver, and then you have a number which you can follow rather than asking the patient to say grade 1, grade 2, grade 3. And the second value tells you how much fibrosis is there. So higher the fibrosis, higher is the fibroscan value, higher is the fibrosis or evidence of cirrhosis. So just remember two values, 8 and 12. If the value is above 8, it is advanced fibrosis. If it is more than 12, it is cirrhosis. So, although I have not presented that study here, recently there was a study published in Lancet from India called the DIA-FIB study, in which diabetologists, physicians, gastroenterologists from across the country contributed data. And it was seen that in a run-of-the-mill diabetic clinic, if a patient walks in with diabetes and you do the fibroscan, 25% patients already have more than F2 fibrosis. They didn't know about it. And 5 to 7% already had cirrhosis. So just imagine 10% of the country's population has diabetes, and of them, 7% have cirrhosis, already having cirrhosis, and they do not know about it. Some of us may be sitting in this room also would be harboring it. I don't know. So here comes the role of this particular molecule called GLP. People have, she talked about this, the glucagon-like peptide 1, which is secreted from the L cells of small intestine and has this multitude of these effects, including cardioprotection, a positive effect on glucose and lipid metabolism and fatty liver. Benefits diabetics by increasing insulin and decreasing glucagon, delaying gastric emptying. Beneficial effect on NAFLD by increasing beta oxidation and improving insulin sensitivity. And one of the central effects, this effect it has on brain, is it reduces craving, it reduces hunger. She talked about hedonic hunger, that is where it acts. So the story started with this molecule, liraglutide. We are talking about semaglutide. Started with this one, a randomized controlled trial of liraglutide, 52 NASH patients given daily injections of liraglutide versus placebo. Those of you who are endocrinologists would have used this molecule, and this was also associated with improvement in histology in patients with NASH, but it led to some weight loss, not the one, the kind which is achieved with semaglutide. So this is the study comparing semaglutide with liraglutide. And as you can see, over 1 year, there was a significant weight reduction with semaglutide, not that much with liraglutide. And I think she's already spoken about it. These are the phase 3 trial based on which semaglutide has been approved by US FDA in all these indications, including diabetes, including obesity, including mast cell, including osteoarthritis, including adolescents. Somebody was talking about pediatric age group. So now it is approved in adolescents between 12 and 18 years of age also who are obese. And all these indications based on the phase 3 RCTs. So this is the important, the first RCT called the step 1 RCT trial, in which 1 year use as compared to placebo was associated with almost 15% weight loss as compared to placebo. So the proportion of patients achieving more than 15% weight loss, almost 50% patients were able to achieve that. And those who were able to achieve more than 20% weight loss were almost 1/3 in this group. Then the issue of semaglutide in MASLD, the kind of the disease which we see as hepatologists. This was daily injection of semaglutide versus placebo for 72 weeks. There was a significant reduction in ALT levels and significant improvement in liver histology. 60% patients till this time, this is 2021, this was the best that any drug could have achieved, and this was the drug which achieved that. But unfortunately, I told you the holy grail of MASH is improvement in fibrosis. This drug, at least in this trial, did not show that. Then came the phase 3 Essence trial, which is planned for 540 weeks. So imagine people do ask, how many months or how many years do we keep giving this drug? So this study is being planned for 540 weeks. The interim analysis was done at 72 weeks of patients with mast cell and F2 fibrosis, even in patients who did not have diabetes. So 45% patients did not have diabetes. Semaglutide in the currently available doses compared to placebo, significant improvement in steatohepatitis and significant improvement in fibrosis. First drug up till now which in MASH has shown improvement in the holy grail of mast cell, that is improvement in fibrosis, and therefore if you extrapolate, possibly improvement in clinical outcomes, but we need to have more data on that. Oral semaglutide also has been associated, before this drug was available or got approval in India, the injectable one, Rybelsus was already available with 3, 7 and 14 milligram escalating doses, and this also showed there was a significant improvement in liver stiffness values. Nobody's asking you to do a biopsy, just do a fibroscan, a follow-up fibroscan, and you will know. I'll skip this. What about other GLP-1 analogs? We've been talking about semaglutide. This is a meeting by Novo Nordisk, but we have to talk science. The dual agonist, tirzepatide, this was a phase 2 trial comparing 5, 10, 15 milligram versus placebo. In India, it is available as 2.5, 5, 7.5, 10. That is how we escalate. And look at this. Even 5 milligram tirzepatide had at least 1 point improvement in liver fibrosis. Again, this is the maximum up till now which has been achieved, but this is a phase 2 trial. Still, it has not gotten approval for use in mast cell. Only semaglutide has that approval. I told you the most common cause of death was cardiovascular. So what if you are a hepatologist and treating MASLD? If you are not able to prevent a heart attack, then it is useless, even if you use this drug. So what about cardiac outcomes? So this was the SELECT trial. Again, a large randomized control trial showed that with semaglutide, there was a 20% reduction in major acute cardiovascular outcomes and reduced death due to cardiovascular outcomes, although that did not reach significance. So this study also showed that not only the MACE events, but also other markers of cardiovascular risk were also reduced with semaglutide, and especially the atherogenic dyslipidemia. And coming finally to the addictive behavior, that's an additional benefit of this particular drug. Darshana did talk about the addictive behavior of eating, the hedonic eating. Eating stimulates especially high sugar, high glucose, high fat kind of food, stimulates the brain's reward center, propagates the addiction loop. More you consume, more you crave, harder it is to satisfy the craving. So it is something like addiction. The lower doses will stop acting. You need higher and higher doses and more food. So, and we have GLP receptor. She did show this picture also. We have GLP-1 receptors directly in the brain, in the hindbrain, in the thalamus, which control your eating behavior. And this drug acts directly there, not necessarily in the periphery also. So, by blunting the dopamine release response to addictive substances, it also affects the hedonic hunger. And not only that, there is also, we are talking about the pandemic of obesity, the pandemic of MASL, but we also have the pandemic of alcohol-associated liver disease. So the alcohol use disorder is also a pandemic these days. And now we have a lot of obese, overweight patients who are also alcoholics. So that is a further menace. It is called MET-ALD. So metabolic dysfunction associated steatotic liver disease along with ALD, called MET-ALD. So this particular drug also is beneficial there. This was a RCT for control of alcohol use disorder. Semaglutide given in 24 patients given placebo, and the percentage change in drinks or drinking days were significantly lower if the patient were receiving semaglutide. Like they have a reduced craving for food, they also have a reduced craving for alcohol. And their weekly alcohol craving scores were also significantly better. So not only obesity, but obesity plus alcohol also gets benefited. Coming to diabetes, so these are the ADA standards of care, American Diabetes Association 2026, that in patients who have MASL and obesity, these are the drugs which should be used as first line. They have done away with metformin. Metformin used to be the first line, but for these group of patients, GLP-1RA, they have mentioned as the first line treatment. And these are our liver guidelines that when you have patient of MASL MASH and you want to treat diabetes, these are the drugs: GLP-1, SGLT2, metformin, and decompensated cirrhosis, insulin. And yes, you have to know your limit. Just all MASLD, just don't give semaglutide. So if you have, I told you, just remember two values of FibroScan, 8 and 12. If you have a patient who has FibroScan value between 8 and 15, those are the groups in which it is recommended. Above that, it is individual preference, the hepatologist's preference. And if it is above 20 or a decompensated cirrhosis or presence of portal hypertension, it is contraindicated, at least as of now. So these are my take-home slides. Semaglutide is suitable for adult patients with a BMI of more than 27. The Western guidelines say more than 30. These are the Asian preferences. It leads to more than 20, in 1/3 patients, more than 20% weight loss. There is a sustained weight loss over 4 years of use of this drug. There is 20% reduction in significant the cardiovascular events. And in patients where we treat them, this is the first and only GLP-1RA which has been approved for use in MASL and MASH, or high-risk MASH. Thank you so much for your patience. I'm happy to take questions. Sir.
Sir, this drug acts on the hypothalamus, and the psychiatric drug also act on the hypothalamus. Those abused persons, old age persons, they have got depression, anxiety. They are on SSRI's drug. Can we use this drug along with that, or because the drug can produce more depression in the patients? What is your view?
So there was some concern about the risk of higher risk of suicide with the use of drug. But that only happens in those patients who were already predisposed. They were already on antipsychotic medications, already on depression. So you have to choose your patients carefully. I completely agree with you, but that patient population is different, in which the suicide risk is increased. But no contraindication of using along with them.
Sir, in very abused patients, when we use this drug, and there is loss of weight and loss of muscles, and their skin become lagging, and this is a different shape, especially in the woman. What do you advise? They go for the plastic surgery, or they should do whatever you advise?
I think again a very important question, a very pertinent one. I think the first thing which has to be done is from the time you start this drug, to counsel the patient regarding resistance exercise and high protein intake in order to prevent muscle loss. But having said that, if you lose a lot of weight, then yes, at some parts of the body you'll have loose skin, and there have been talks about or reports about plastic surgery being needed following the use of this drug. If you lose the weight rapidly, if you don't lose rapid weight, then I think this can be prevented.
Cost is much higher as far as the drug is concerned, as well as the plastic surgery is concerned.
No,
But I would
finally,
say, sir, that given the, if you look at the, sorry, but
Yeah.
the denominator of the number of patients who are on the drug versus those who come into the category of maybe perhaps requiring plastic surgery could be very less. And as Dr. Kaushal said, I think the big caution with us practitioners should be that take it slow and steady. That's really important. You know, I tell my patients that whatever it is, even if you're going to plateau, I am not going to increase the dose. And that's the difference between coming to a practitioner who is able to treat correctly versus in a pharmacy and doing your own. So you have to have that caution rails so that your patient does well and doesn't fall into yet another massive high.
just give an example of what she just said. So you may have a person who has 100 kg weight and his ideal weight is 60. You are not aiming at breaking down his weight from 100 to 60 next 6 months or 1 year. You have to go slow. So maybe over next 2 to 3 years you want to come down to 60, not in one first year. So if this person comes down from 100 to 60 in first year, then he'll have a lot of complications, no doubt about that, and you'll have to manage all this. One of them will be this.
So if a person is having a satisfactory loss of weight with some certain amount of milligram of drugs, would you advise to maintain the drug at that stage or stop the drug for some time and regain, because the
Absolutely.
weight again will be within 6 months to 4 years?
Absolutely.
What is your idea?
It is recommended that if 1 milligram is leading to a significant weight reduction and you are continuing to lose weight, albeit at a slower rate, still you continue on that. There's no need to increase it. If it plateaus and you want to achieve further weight loss, only then you increase it. I agree with it.
How long can you continue this drug?
Great question.
So I think that's why I presented that. So
It is,
I think
yeah.
up till now there is
How
rebound.
long should you?
Yeah. So I thought
When you stop it, there will be a rebound.
up till now there's data of 4 years. Now diabetes is a lifelong disease. You keep giving it lifelong. So if you are considering obesity also as a lifelong disease, till the time patient changes his lifestyle or her lifestyle,
You are hoping
keep
for that.
giving it. Yeah, hoping for that. But I agree, it's impossible to take an expensive drug like this lifelong.
एक बार चालू हो जाए खत्म नहीं होती.
That's also a problem. The moment you stop it, there's a rapid rebound in hunger.
You can no longer afford it.
You can no longer put food also. That is a better option.
So lifestyle change हो गया.
So are there any contraindications or any special groups where we have to be cautious before we put them on this drug?
So patients who have symptomatic gallstones, simple gallstone without symptom is still not a contraindication, but it has to be discussed with the patient that there's an increased risk of the gallstone becoming symptomatic, or a patient who does not have gallstone getting a gallstone. Although risk is small, but that has to be discussed. Second, if a person has had severe acute pancreatitis, it is a contraindication. While on this drug, if a patient develops pancreatitis, should be avoided. And obviously, lean patients, like somebody said that people are using it for cosmetic purposes. So already lean patients using it to further reduce their weight, that may be a problem.
Right.
Are the chances of pancreatitis
You
more?
lose your muscle also. A lean person losing muscle is probably worse.
And what the incidence of sarcopenia, मतलब how much weight loss percentage wise, how much is the muscle loss and how much is
Almost
fat loss?
20-25%.
So can that be mitigated?
Out of 10 kgs, 2.5 to 3 kgs would be muscle and bone. Muscle and bone.
And bone.
Lean,
So can that be mitigated by, let's say, a high protein diet or
higher
doing
protein
resistance
diet and
exercise?
resistance exercise.
Right.
How do you have to force yourself to eat? At one point you are stopping your hunger and then you're forcing yourself.
Whenever you eat, possibly make sure that there is more of proteinaceous content and exercise.
So it can be mitigated. So that can be reduced.
And again, that is possible only if you are losing weight slowly. If you are trying to lose weight very fast, then it's a problem.
Yes.
So that means osteopenia should also be a contraindication, would it be?
Yeah, but there is no guidelines to suggest that you have to look for all this. But yes,
Pancreatitis, many two problems, multiple endocrine
Polyps in the
tumors,
gallbladder
and thyroid cancer. These are the absolute.
medullary
That's
carcinoma.
not these are the absolute contraindications.
Medullary
Sorry, Dr. Amit
How
has
about
Gallbladder
diabetic
polyps.
retinopathy?
Yeah, so not so proliferative diabetic retinopathy is a contraindication. So that is what people have moved on to. They at least get a fundal examination done, especially in diabetics, before starting.
And again, the problem
All
comes
that-
adding on is the
polyps.
rapid.
Are there contraindications? No.
Dr. Amit has been trying to answer.
Have all these drugs and
No, all that.
we have to use them indefinitely or maybe for so many years. So how do you choose a patient between taking these drugs and getting a bariatric surgery done, which is a one-time procedure and an everlasting result? So how do you choose your patient between a surgery and a medication?
So I think yesterday also I was asked this question. So if a BMI is very high and you want to rapidly reduce, I think the best way to do is you first go for bariatric surgery. When the weight plateaus, then you add this one. So some people are combining mechanical means of weight reduction like bariatric surgery or endobariatric. So nowadays we are able to do the same kind of surgery endoscopically called endoscopic sleeve gastroplasty and combine that with GLP-1 RAs. So then you get a better result. You do one thing, the weight plateaus, then you do the next thing. Either can be first, but there are no recommendations.
No, but if the patient also has a fatty liver, say if the patient has grade 3 or grade 2 or 3 fatty liver, then doesn't putting them on the drug makes more sense rather than putting them.
Because it has so even bariatric surgery has shown that if you lose weight significantly, their fibrosis, a lot of them will reverse their fibrosis. So with GLP-1 RAs, there is some effect which is weight dependent and some effect which is weight independent. So it has definitely a dual advantage. And one more thing before, since I am also a gastroenterologist, and you talked about the procedures, I told you about one procedure is ESD, the second is balloon. So a lot of people used to get a balloon placed, which stays in the stomach for say 4 months to 9 months, and then it has to be removed. Again, it is a reversible procedure. It only leads to a weight loss of about 10 kgs, 10 to 12 kgs. And somebody mentioned about using this drug just before marriage. and somebody mentioned that this balloon, people call it bride's balloon. Because, so the lady will get the balloon inserted endoscopically just before marriage, say 4 to 6 weeks or 12 weeks before marriage, lose about 10 kg and subsequently get it after 3 months it will come back.
The wedding industry is it's massive in ways that we didn't realize. Right. Yeah. Any other questions? Yeah.
In the case of the gastric emptying, so what is the term the gut biome?
Not gut biome. So mostly the gut biome is located in the large intestine and distal small intestine. So usually, since there is acid in the stomach, there is usually no bacterial growth except for H. pylori whenever that happens in the stomach. So that doesn't happen, but yes, it reduces gastric emptying, increases GERD, and sometimes increases the risk of aspiration that we should be aware of.
For patients going on getting surgery, many of you are surgeons here. I think that's something that you say be aware of if they're on these drugs because of what doctors say.
The fasting period has to be longer. So normally you go in for a surgery after overnight fast. So maybe yeah. But again, the guidelines vary, controversial. Some guidelines say no need for a prolonged fasting. Some say.
Can I ask one non-GLP related question? So people come in with ultrasounds, they're coming in with fibroscans. Us as general practitioners, should we be getting for a grade 1, 2 fatty liver fibroscans for everybody? Should we be, if they show up with a fibroscan, still getting an ultrasound? What are your
Again, a
thoughts?
very important question, because the algorithm for the primary physician is that you use FIB4. FIB4 score or
Yeah.
NAFLD activity score. FIB4 score you just have on your Google. Just there's a formula there. Just enter AST, ALT, age, and platelet, and you get a FIB4 value in just 2 minutes sitting in the OPD. If it is more than 1.3, then you escalate to a fibroscan. If it is more than 8, refer to a hepatologist. If it is less than 1.3, keep the patient. So, if all physicians keep referring all fatty livers, will be overwhelming. So, for that, primary physician algorithm is FIB4.
These formulas should be sent by Modi to everybody.
Use DocGenie, we're putting them all there.
FIB4, FIB, fibrosis,
USS.
4.
4
4 numerical. Just enter on your Google, you get the calculator. Just enter the values and you get the result.
Well, I guess no more questions. So thank you.
Thank you.
Thank you to Dr. Madan, and all of you, and to the Novo Nordisk team.
Group photo. Yeah.
Yes, sir.
Yeah.